Hello and welcome to Patient Power. I'm Andrew Shore. In this edition of our Ask Dr. Berenson series, we're going to discuss how to manage the side effects when you're living with multiple myeloma. And so with us, of course, again, is Dr. James Berenson. He's the founder, president, and CEO of the Institute for Myeloma and Bone Cancer Research in West Hollywood, California, Los Angeles. Dr. Berenson, thanks for being with us once again.
Thank you for having me.
Dr. Berenson, lots of questions. We want to discuss things like numbness, of course, and peripheral neuropathy, fatigue a lot of people have. Some people complain of foggy brain. There's a worry with some medications about clots and also GI issues for some people, and even, I know you want to bring up shingles. Let's take them one at a time. Peripheral neuropathy. It is a complaint people have with myeloma medications. What can we do to limit it? And I've often wondered, if you've lost some feeling, can you get it back?
Yeah, so peripheral neuropathy is a major problem today in myeloma patients, and it's largely from treatments, drugs such as thalidomide, the worst offender, Velcade, and to some extent even Revlimid or lenalidomide. But the myeloma itself is associated with a higher risk of peripheral neuropathy. Many patients present with numbness or tingling, and it's because the antibody itself can bind the nerves and mess up their function. There have not been really any good randomized studies showing that specific drugs will reduce this risk. However, that being said, we do try a number of products. Over-the-counter things such as alpha-lipoic acid I use commonly, and I don't wait for neuropathy to occur. I start patients on 600 milligrams daily on this over-the-counter medication. This has been proven effective in randomized studies, not in cancer patients, but in diabetics with neuropathy. Otherwise, there have been a number of prescription products that have been tried, gabapentin or Neurontin, drugs like Elavil, Tofranil, Topamax, other drugs have been used, such as more recently Lyrica. These have not really been proven useful yet in randomized trials, however. In general, the answer to neuropathy is less drug per month. So we know with drugs like thalidomide and now from our recent studies with Velcade that if you bring the dose intensity down per month, you markedly reduce the risk of neuropathy from these drugs, that is thalidomide as well as Velcade. In addition, we now know that the route of administration matters for Velcade. There's a recent French study that shows that giving the drug on a subcutaneous basis with the same FDA-approved schedule will also reduce the risk compared to the intravenous that has been used up until now. So again, reducing the dose per month, changing the route, and some people even believe that if you change the schedule to weekly for Velcade, will also reduce the risk. However, the weekly schedule may be also a reflection of less dose intensity per month. It may not actually be a reflection of the change in schedule.
Now, I know it's always important, though, if people are having, let's say, neuropathy, to communicate that right off the bat when they're noticing it to their healthcare team.
Yes, I think it's important to communicate it because oncologists often do not ask that question. So the incidence of neuropathy has been growing as we become aware of it. The early studies with Velcade were 30%. The more recent studies are 60 to 70% of patients. However, again, modifying the dose, the schedule, as well as the route of administration can greatly reduce this number. We're starting studies now with subcutaneous using our modified dose and schedule, and I expect, I should say, that the incidence of neuropathy is going to be in the 10 to 15% range. And in fact, using our modified dose and schedule in a recent publication using this schedule again, we have now found that all of those patients had reversibility. Unlike the conventional dosing, in which about 2/3 will reverse and not completely, 100% of eyes not only reversed but completely went away. Thalidomide, on the other hand, rarely reverses. And if you give the patient a re-exposure to thalidomide again, say in another combination, the patient will have more neuropathy. That's not true with Velcade. Many patients can get re-challenged with Velcade, even using the same schedule, the same dose, they won't have neuropathy when you re-challenge. So it's important to recognize just because you've had bad neuropathy before with Velcade doesn't mean you're going to experience it again.
Dr. Berenson, because of side effects, sometimes people switch drugs. Let's say maybe they switch from Velcade to Revlimid. Maybe then they're having some side effects there and they wonder, could they switch back? Would Velcade be effective a second time?
Yeah, a very important point is that Velcade makes other drugs look much better. I like to compare it to dancing with my wife. I can't dance very well, but she makes me look better on the dance floor. And that's what Velcade does. So it makes drugs like Doxil, dexamethasone, Cytoxan, Melphalan, all these drugs work much better when they're combined with Velcade. So just because you're filling Velcade, say, with Cytoxan, doesn't mean you're not going to have a great response with Doxil. And I also would tell you that's true with thalidomide or lenalidomide Revlimid. If you fill Revlimid, you may respond beautifully to substituting thalidomide instead of the Revlimid.
So you can switch around.
Now, we even know that increasing the dose can be effective. So, for example, I tend to use lower doses of Revlimid because I don't like the 25 milligram dose. So we start everybody on 10. And if patients progress on the 10 and then you bump the dose to 25, many of them will respond endurably for a long period of time.
All right, let's go to another key complaint that people have, and that is fatigue. We had one man write us. He said it's hard for him to get out of bed. What do we do about the fatigue that people suffer from with myeloma and in treatment?
Fatigue is the number one issue today in myeloma. Fatigue, I can't think as quickly as I used to or clearly. I have memory loss. This is a huge issue today in myeloma, and we do not deal with it very well as oncologists because we are not psychiatrists and we're not neurologists. But if you really measure it, most patients experience myeloma and myeloma drug-related fatigue. So it's both. We are actually now conducting a randomized study using a stimulant called Nuvigil, a follow-up product of Provigil, which has been used, for example, for narcolepsy. People fall asleep suddenly. And I think these are wonderful drugs to try in cancer or cancer drug-related fatigue. We don't have the results of a randomized study yet, but at least anecdotally in patients I treat, these are great drugs. The problem is a lot of them are not approved for use. Some people try Ritalin. I don't think it works as well as Provigil or hopefully the Nuvigil does. The other thing that can be done again is reduce the dose, and this will make a big difference. And I think you recognize that a lot of this is drug related because when patients stop the drugs, their mind goes back to work like it used to. So I do believe the drugs do this. I don't think we do a good job of measuring it. I'm really pushing now that in all clinical trials, we require a neuropsych assessment on an ongoing basis to see what we're really doing to patients' minds with this long-term treatment.
Now let's just break out foggy thinking for a second from fatigue. So fatigue is a big complaint, but so I've heard with lenalidomide, people sometimes complain of this foggy thinking. So you talked about dosage, or would that be an argument for someone to switch to a different medicine?
Usually the fatigue can be dealt with without discontinuing drug. I would strongly urge you to also have your thyroid checked. And believe it or not, if you're a male, your testosterone. A lot of patients have low testosterone, and that certainly is probably a contributing factor in men to the fatigue and just not feeling up to par.
And not feeling sharp.
And not feeling sharp as well. So I think that we certainly need to have this addressed much better than we currently are in the myeloma field.
Okay, let's talk about some other side effects that people complain about. We talked about fatigue. We talked about numbness, of course. Now, I understand there's a risk of clots. Talk about that and what do you do about it?
Yes, it's important to recognize that people with myeloma in general, and even its precursor MGUS or monoclonal gammopathy of undetermined significance, have a higher risk of blood clots. It's not only clots in the legs, clots in the lungs, it's actually as well arterial clots, heart attacks and strokes. This is not only drug related is what I'm trying to say, it's disease process related. So even MGUS, without those patients being treated with offending drugs, those patients are at higher risk as recently demonstrated in several large studies. That being said, we know that certain drugs are certainly big bad causative agents. Those include thalidomide, lenalidomide, and probably the yet to be approved agent, pomalidomide. All these immunomodulatory agents, not alone, but when they're combined with glucocorticosteroids, those are drugs you know as prednisone, dexamethasone, Medrol or Solumedrol. these drugs with thalidomide or lenalidomide will increase your risk of clot. And importantly, that risk is usually occurring the first few months. So we highly recommend that anybody who receives steroids with an IMiD, thalidomide or lenalidomide, goes on baby aspirin. Should they go on Coumadin, Lomanex, Pradaxa? There's no real evidence that that will be superior to simply baby aspirin. We don't really know why baby aspirin works, but it does, because it really shouldn't work in venous. It should just work in arterial clots. Really importantly, the risk of clot, just like the risk of a lot of these things, is related to not only the amount of the IMiD, but the amount of steroid. So with less steroids, as we've observed, and also in the Eastern Cooperative Oncology Group, comparing high to low dose steroids with lenalidomide, the risk of blood clots is much lower. So we have never seen that many clots in our own practice because indeed we use much lower doses of steroids. In addition, however, it is important to point out that a lot of people have unrecognized clots. In fact, one of my colleagues, every time he admits patients to the hospital as part of the routine workup, he gets Dopplers to look for clots. And guess what? The two he admitted over the weekend while I was in New York both had asymptomatic clots that needed anticoagulation. So we're probably missing a lot of clots.
Well, I've been treated for a deep vein thrombosis found with Doppler ultrasound, so I'm well familiar with it. Dr. Berenson, what about shingles? We're right at a time now here in the fall of 2011 when people are wondering, should they get flu shots? Should they get a shot for shingles? And what about shingles as a complaint for myeloma patients?
Okay, first of all, let's talk about vaccines. Well, it's our recommendation that you get a pneumovax, a pneumococcal vaccine every 5 years. It's also a recommendation that you have an annual flu vaccine. Do these work? Probably not very well in myeloma patients who have what we call immunoparesis. They don't make antibodies very well, and they probably have pretty darn poor immune responses to immunizations. That being said, we still recommend it. However, we do not recommend live vaccines, and that includes the herpes zoster or shingles vaccine. You should not get that if you have myeloma. It's a live vaccine. But we do recommend that any patient who is on Velcade should have ongoing antiviral prophylaxis. We usually use acyclovir, but the new patient I saw today doesn't like that drug, and so he's going to go on Valtrex. You could try Famvir, but you need to stay on that drug as long as you're on Velcade and probably about 6 weeks after your last dose. If you don't undergo antiviral prophylaxis with one of these drugs, your chances of having herpes zoster or shingles is about 20%. And that is not a nice thing to happen because you can have ongoing, what we call post-herpetic neuralgia, ongoing pain forever the rest of your life. And it's just a pill, you take it, and then if you take those pills, you're not going to have it. The only two patients I've seen develop shingles in my practice, one guy decided he just wasn't going to take it anymore, and the other went to the pharmacy and they filled the wrong drug. And that patient ended up with shingles too. If you take it, you're really unlikely to get shingles with your Velcade drug.
What about GI issues? Now, of course, many people have had transplants. They wonder, is it from the transplant or is it from other drugs, but they have continuing diarrhea, GI issues. What about that?
Again, this is a multifactorial issue. It may be other problems in the GI tract that have nothing to do with the myeloma or drugs, but it may be related to not the myeloma, but something that can happen in myeloma called amyloidosis, in which the protein can coat the gut and cause GI issues. It's a breakdown product of the antibody that is the hallmark of myeloma. That can be a cause. You can also have drug-related causes. For example, constipation is very commonplace with both Revlimid and with thalidomide. On the other hand, Velcade may cause diarrhea or constipation. And again, this is clearly dose-related. Giving less drug markedly reduces the number of patients who have diarrhea, for example, with Velcade, as we've shown in some of our trials. Also, the diarrhea may be from bacterial overgrowth. It may be from antibiotics that you're receiving for other reasons. We know that, for example, Clostridia difficile or C. difficile associated with diarrhea is not uncommon among patients who are getting antibiotics to treat other infections they may have. We also know that patients may have bacterial overgrowth syndromes, and we find that low-dose antibiotics will help that group as well. That is not uncommon to occur.
I guess when you tie all this together, Dr. Berenson, I mentioned communication earlier. There are all these things that could come up, either from the myeloma or from the medications you're taking, or maybe just from your overall health or some other condition you have. But if you're communicating with your healthcare team, hopefully there can be some relief.
Oh yeah, I mean, we deal with these all the time, and we work with patients, and we really try to individualize the therapy to meet their needs so that these side effects are reduced. Because as I like to say, it's not about complete response, it's about our patients having a complete life. We like to deal with the patient, not just the cancer.
Dr. James Berenson from the Institute for Myeloma and Bone Cancer Research in West Hollywood, California, thank you so much for being with us and answering the questions that people have been sending us and talking about the management of side effects. Thank you so much for being with us.
You're very welcome.
I'm Andrew Shore, reminding you from Patient Power that knowledge can be the best medicine of all.